I'm pleased to sort of, kick off this event and welcome everybody. It's a wonderful opportunity to celebrate you, Michael, as an individual, to also celebrate the scholarship that's in your name. And I hope to really have us see the incredible impact that both you and the scholarship have actually had on the Canadian healthcare system. And that's sort of the big sort of vision of how we move forward. That's where I guess the watch has been clearly would not have been the right gift, where this has been and provided much more of an impact. But when Michael concluded his time on the board as our board chair, and it was about 10 years on the board, and it's been now about 10 years, Michael. So we're all sort of aging well, is the way I would describe it, versus getting old. But Michael was an incredible leader for me to work with St. Eliz, now SE Health, for a couple of reasons. Michael trusts people and gives you the freedom to either make big mistakes or big things to happen. And I'm pleased to say that we made a few little mistakes, but we did make some, I think, big decisions that impact not only the healthcare system, but people in particular and individuals. Michael was so supportive with our First Nations work and our Indigenous work from an external point of view, and doing the right thing because it was the right time and we had a right solution for them, to helping me and my leadership position St. Eliz for the future. And quite frankly, bringing out the best in me. And that really allowed us to bring out the best in all of our leadership and staff at SE Health. And with this scholarship, it moves to bringing out the best in everybody else, external to SE, and all that you do and all that you touch within the healthcare system. So it's actually, quite magical. And I do think it really talks about much of the commitment and volunteer commitment that people like Michael have to participate on health boards, but how they have such a large impact on what's really important. And sometimes we forget that we say, yeah, they were there for 10 years and isn't that nice? We're really saying this is continued in such an important way, not only internally with our staff at SE, but externally for all of the talent that exists within the healthcare system. And it's actually a privilege for SE Health to be part of this in a much bigger way, both with everyone who's received the scholarship, and also Michael, with your, I would say, your entire career commitment to health, to healthcare, but even more importantly, to people. And I think that's probably my most important message, recognizing the scholarship and Michael Decter's name associated with the scholarship. Now I'm going to turn it over to Nancy, who has been for years involved in research, education, knowledge, and now is very active within all of that and our operational lead in the entire organization. So I'm pleased to say she's put up with me for all of these years. I know we have brought out the best in Nancy over these years for so many things that we're now doing. But again, this particular initiative speaks to it in, again, a broader way of sharing our knowledge, our education, and competency. So I'll stop there. I don't know, Michael, I thought you maybe wanted to jump in. So maybe before Nancy starts, did you want to jump in or no? I was just picking up the vibes.
I'm blushing. And, but
don't
I'll
blush.
Go after Nancy. That's
it's
fine.
Very heartfelt, yes, what I'm saying, Michael, and it is, we many times don't recognize the impact that people have. And we kind of dismiss and go, well, thank you very much. That was very helpful of you to give us your time. And we really don't help people understand how valuable they have been to certainly the history and today's view kind of world of SE health, but even more importantly, our future. And because it really will be the future for society improving much more than even just as the organization is improving. So I'll stop there and kind of, Nancy, over to you to talk about your favorite little project, knowledge, education, talent, empowerment. So over to you.
All right, thanks, Shirley. And it has been a pleasure and quite a wonderful experience that I have had in the organization. I thank you for the opportunities, both Shirley, yourself, and Michael over the many years that I've been there. But it is hard to believe that it's been a decade, and I'm so proud of the scholarship and the recognition for you, Michael. But as Shirley said, the recognition and the impact and the I guess the impact that it has had on other people. And I'm proud of all the students who have gone on to do such amazing things with this scholarship. So Shirley and Michael, as you know, we would have lunch, used to have lunch every year with the winner. And I have lots of memories of the great conversations we have had. And I probably enjoyed those lunches as equally as much as did our scholarship award winners. And so today I'm excited to get started with another great conversation with our panel of past winners. But I'll start with our guest of honor, Michael. Michael Decter, and in terms of introductions, is a Harvard-trained economist, healthcare leader, and the inspiration for this scholarship. He's currently the CEO of Lawrence Dector Investment Council, Incorporated, in addition to being our past board chair from the year 2000 to the year 2010. He was also the Deputy Minister of Health for Ontario. As Shirley mentioned, his contributions to healthcare in Canada cannot be underestimated or understated, and we are so grateful for his time at St. Elizabeth, then St. Elizabeth Healthcare. Next up, we have Natalie Warrick, our winner from 2013. Natalie earned her PhD in Health Services Research and Health Policy from the University of Toronto, where she focused on advancing knowledge and supports for caregivers. She's now a manager, Allied Health, at Scarborough Health Network, where she leads over 100 healthcare practitioners. Thank you, Natalie, for joining us, and it is great to see you again. Next, we have Martin Coyle, our winner from 2019. Martin will still have to book that lunch with yourself. Martin is pursuing his International Masters for Healthcare Leadership at McGill University, where he focuses on developing an intervention for second victim syndrome and its impact on burnout and patient safety in medical students and graduates. He is currently a professor at the University of Toronto's Institute for Health Policy, Management and Evaluation, and the director, Pediatric Urology at SickKids. I'm glad you could join us here virtually today, and as I said, we'll get that lunch in. Finally, please welcome Reza Hosseini. This is our 2020 winner, so congratulations, Reza. Reza is our first winner in BC, and on an international level as well. And he's currently pursuing a Master's of Public Health at the School of Population and Public Health at the University of BC. Reza hopes to complement his clinical knowledge with a broad public health perspective to address the root causes of health problems in our communities. Congratulations, Reza. We can't wait to see what you do next. Now that we've introduced our panelists today, Michael, I'd like to hand it over to you to say a few words and to bring us into today's discussion. Thank you.
Well, thank you for all the kind words. But we've got limited time and a good conversation to be had. So I will try and briefly set the stage a little bit. And what triggered this for me was a call from one of the researchers at TVO earlier this year, I guess, who said, you know, we've got this Commonwealth Fund study and other studies, and Canada doesn't look very good. We don't rank very high. Why do you think that is? And I remembered that I'd been asked a few years ago, Bob Bell was Deputy Minister of Health, so it's at least 3 years ago, to go to Washington. The Commonwealth Fund had done a study really looking at connection in health and continuity of care and all of those issues about how patients move through the system. And they do big surveys. So they've done a big survey of, I think, 12 countries, but it might have been 13. And so it was a summit meeting at a very posh club in Washington with the leadership team from the Ministry of Health in Ontario and some leaders from the hospital and health system. And then the US counterparts, so the people running Medicare in the US, the people running the big government programs, and some other kind of thought leaders. And we spent 2 days, and it was completely fascinating. And I would have loved to continue to chair those meetings, but I put my foot in it in the summation when I said, this has been great. We've learned a lot from each other. But in the survey, Canada ranked 11th and the US ranked 12th. And the Australians were first and the Brits were second. And maybe if we're going to do this again, we should get them to come so we can figure out why they're first and second. That wasn't taken as well as I'd hoped as a kind of suggestion for the future. Canadians and Americans are extremely proud of their health systems. They're also extremely critical of their health systems until someone else outside of Canada is critical, and then we all group together and say, it's the greatest system of all time. In many ways, we should be very proud of what we've achieved. It still lacks some of the connectedness that it needs to be, a fully functioning modern health system. But what always saves it is the high quality of our providers. I mean, we really do have, a fantastic community of providers in Canada, trained as well as anywhere. Many of our leaders in healthcare have gone elsewhere for training, so we bring back what the learning that's going on at Hopkins or Harvard or in the UK. So that's a major strength. We have two, I think, major weaknesses, and they've come to the fore in this pandemic period in a very visible way. The first is we have a population now of over 1 million Indigenous people in Canada who have a health status and living conditions that are, for the most part, far worse than the rest of our population. So life expectancy has gone up for Indigenous people. It's gone up for the rest of us. But the gap of about 8.2 years has stayed, has been a persistent gap. And it doesn't take much travel in the north and in other parts of the country to see, poor housing, all of the social determinants of health that aren't properly supported. And there's hundreds of years of explanation for that. But I do think in this period of pandemic, it's become not only a stark, visible reality, but it's also become clear that it's hard to contain a pandemic if you have a population that are vulnerable, that are, not under the umbrella in a full way of health services. So that's one. And I think the real answer to changing the curve for the Indigenous population is not particularly health services, although those are needed, but I think it's education. When I, as Chancellor of Brandon University, see 20% of the students graduating shake their hands, not this year, but in most years, and they're always the first one, or almost always the first one in their family to ever go to university. But when I look at the family in the stands and there's 2 or 3 younger brothers and sisters, I know they're all going to go. So what transforms, as it did for my father's family and my family, is getting that first foot into higher education. And that is, we have now a significant number of Indigenous teachers, social workers, more and more physicians, nurses, and they serve as role models when they go back to their communities, and kids look and say, hey, I could do that. I could, for a long time, when you went in those communities, and I did a lot of that in the 1970s when I was in the government of Manitoba, all the good jobs were white people. The Indigenous people were not people providing healthcare or providing legal services or even policing. So you need the role model, and then you need the pathway. The second issue we have is connectedness, and I'll be a little anecdotal here. I have a sister who lives in the north of England, and she called me on December 8th, and she said, I just had a call from my GP's office, and they've given me a date for my vaccination. And I thought, okay, I'm going to start the time clock and see when I get that call in Canada. And I have a very fine family doctor who was part of the group at Mount Sinai. And the call came yesterday from the office to say, have you been vaccinated? And I said, I have to tell you two things. One, I was vaccinated a month ago at the pharmacy in my office building. And two, I was tested positive for COVID 3 weeks ago. I had a pretty rough week. I'm fine now. But thank you for the call. And I had tried to call my family doctor's office back before, actually around the time I was diagnosed. And there was a message on the machine that said, don't call us about COVID. We can't get you it was a kind of, we can't do anything. And I thought how wrong that was, that we wouldn't have engaged, the family physician workforce. We didn't engage home care. I mean, in my vision of it, we would have been doing from day one some of the things we're doing now, having nurses and paramedics go into people's homes and vaccinate them, vaccinating all of the people who are at risk in neighborhoods or in long-term care. It took us a long time to get there. My sister got an appointment in January. She and her husband went. They were vaccinated, early in January, and so just say the English system, the national healthcare, has many critics, but they do have a much more connected primary care system. You are enrolled with the GP. Now, I'm enrolled with a GP, but the GPs get to do more, and they get to be more engaged with their patients. And I think in Canada, we've got an excellent system of academic medical centers. They're as good as anybody's in the world. We have excellent care at the community level from physicians. We have excellent home care services. What we don't have is those things working together. And what we often don't have is the work being done by the most effective provider closest to the patient. And I think we have a lot of work to do there. I hope when we come out of the pandemic that people will roll up their sleeves and sit down and figure out how to make the Canadian care system be truly a community-based care system. And I say that because we still have so much in hospitals that could be done outside of hospitals. And then we end up in this horrible dilemma now when we've got critically ill people who need a bed, need an ICU bed, need a ventilator. How do we find that room? We bump what gets called elective surgery, but often isn't. I mean, it's elective because you can get a pretty good result doing it in a little bigger window, but you can't stretch forever. And in some cases, there are real consequences for patients of the delay. And at least some of those things could be done as they are in other countries, in freestanding surgery centers that can be affiliated with a hospital. And we have a little bit of that, but we've been reluctant to step away from the old model. So I'm always an optimist, and I'm always impressed at the coalface with what people do and how well they do it and how dedicated they are. And I will say, case of Medavie, where I'm board chair, and we haven't said anything publicly, but our paramedics, because there's very low caseloads in Atlantic Canada. So we've got paramedics who volunteered and are working in Northern Canada, in communities in Saskatchewan, and they're testing and they're vaccinating and they're they're dealing with people, and it's sort of below the radar. I mean, we were asked to do it by the government of Canada, and we were surprised at how many of our people were willing to volunteer and really put themselves at risk, because they're going into communities where, you know, some of the communities have 30-40% people testing positive, and they're coming from New Brunswick or Nova Scotia, where, you know, in a big day, 3 people in New Brunswick test positive. And you've had, in some of the northern Manitoba communities that I know, out of 3,500 people, you've had more cases than Atlantic Canada's had in total, which speaks to vulnerability. So I'll stop there. I'm delighted to be part of this, and I hope I've said things that you know, spark a bit of discussion or disagreement, but I'll stop.
Great. Thanks, Michael, for some great foundational comments in terms of moving our discussion forward. So I have some questions, but before throwing them out, I just wondered if, you know, Martin, Natalie, or Reza have any kind of response to any of Michael's immediate comments.
I think Michael's hit the nail on the head in so many ways and sort of stole a lot of the thunder of our conversation. But the reality is, I left Canada in 1976 when I finished medical school and returned in 2011. And it was as if I had walked out the front door, come in the back door, and the table was set exactly the way it was in 1976. So I think there's been a reluctance to change. And as a surgeon, Michael brought up the issue of things like surgery centers. We are never going to catch up with the number of cases that have been canceled due to COVID unless we adopt new systems and think out of the typical thematic systems that we have in the past. We have to be very adaptive. This virus has been adapting to us. We have to adapt to the virus in a similar fashion. So just a quick comment.
That's a great comment. Thank you for that. And it rings all too true. So that's sort of stuck in time. Yeah.
You know, one of the things that, you know, we've learned in our own organization through the experience of COVID is certainly the significant connectedness, or the impact of the connectedness and the collaboration that took place as a result of COVID, and really the great strengths of the system. And I think we've seen that in our overall Canadian healthcare system. I think it also is a time that shows a lot of gaps. And I'm wondering if there's some comments around, you know, based on what we've learned through COVID, that we can use to improve the healthcare system. I mean, you raise a good point in terms of surgery centers and having something like that we need to do to be able to catch up with things. But just in overall, I'm wondering if you have any comments, each of you, from your own perspectives in terms of perhaps some learnings and some opportunities that exist. Natalie?
Thanks so much, Nancy. What COVID has really taught us is the value of virtual strategies. So, for example, patient-accessible electronic health records are being implemented at an international scale, and COVID is truly accelerating their use. It's widely known that adoption rates are pretty much the highest in, you know, Northern European countries, with rates as high as 80-90% adoption. Around 45% or so in the US, and far less extent in Canada. I would throw numbers out there, less than 10%. At the Scarborough Health Network, we're investing in a new clinical information system, EPIC, which is in the US, there's pretty much 2 systems. There's EPIC and Cerner, which are the 2 major, you know, clinical information systems. And, you know, we have done similar things across Canada with the implementation of EPIC. And, you know, what I'm really looking forward to is its actual companion product, which is a patient-accessible electronic health record system called MyChart. And what this does is it allows patients for the first time to really have a portal with which they can easily communicate with their healthcare providers, be it a physiotherapist, their inpatient intensivist, whoever it is that they need to communicate with. They can get access to lab values. They could get access to whatever information that they feel is necessary. They can schedule appointments and visits. And what COVID has really brought to the forefront for me is, you know, an operational leader of an outpatient ambulatory care setting where we work very closely with the surgeons, you know, to the point earlier about how are we moving dynamically in the environment to, reduce wait lists and to get the, surgeries done for these folks that need them. And we've done that in close consultation with our ambulatory by getting people access to appointments more readily, by moving from, a model which was 2 to 3 days inpatient admission to same day post-op day 0 discharge, and working closely to implement new changes that coming out of the ministry with respect to bundled funding. So these new changes in funding models, the new changes in the surgical techniques, and really convincing the patient at the end of the day, I've got a patient navigator, here's their card and their number, here's how you get your record, here's what your outpatient physiotherapy appointment will be, and reassuring them that going home the same day is okay, because the challenge becomes someone had their knee done 5 years ago, stayed on an inpatient basis, then went to an inpatient rehab, then went to outpatient rehab, and now we're taking them from their surgery to same day discharge to just outpatient. So it's a huge jump for people, and change always takes time. So final sum, COVID has really brought to the forefront that things can be done virtually. Thanks.
Reza?
I just wanted to add, as you know, I'm a bit new to the Canadian healthcare system, so please correct me anytime. But one thing that I was thinking was interesting about COVID is its impact that it had on influenza cases over the past season. And we've seen that these public measures that has been implemented throughout the country has resulted in 0 influenza cases in BC, at least until mid-January that I had the numbers, and very few cases across Canada. So I was thinking maybe if we could implement some of these public measures, some sort of them that has become kind of habits right now, and these behaviors might be able to help us control infectious diseases like influenza or measles in the post-COVID era.
Yeah, good point. Shirlee, you wanted to jump in there?
Yeah, I was just going to jump in on a couple of things, building on actually Reza, your comments of and Michael, your comment. If we really get on the other side of COVID and actually can, rather than how fast people can get discharged from the hospital and get the best care, which is obviously very important, but actually if we could keep them out of there in the very first place and use very different techniques and funding and vaccinations and immunization, and that is not going to happen unless we recognize other power structures, resources, and professionals like the paramedical group, where Michael, you're so right to say they're doing a lot of things, but that's under the radar. A lot of the home care work under the radar, not only under the radar, but compromised in its ability to actually do what it needs to do. And we talk front door and back door. I would just love to see people's front door of their house, and that they could stay in there where they want to live and where they want to enjoy life and where they want to die. And that we actually create that front door for them to actually be closed so they can do what they want to do there. But instead, all of our doors are typically hospital doors, back doors, side doors, and it tells me still we're orientated towards sickness, hospital, and the thing is, it's critically important. So you get these polarized discussions where it's like right away someone will say, well, so Shirlee, are you saying that's not important? I go, actually, it's enormously important, and it's enormously important that we protect it and build it, like what they've done in Denmark. They actually now, by virtue of for 20 years supporting the community in a very different way, are actually now creating amazing acute care centers because they have stabilized what's happening. I hope with COVID, we can shift things, but I will tell you, we continue to be preoccupied with the back door of the hospital. And there is so much that could be done front end. And it's critically important we start to shift, because if we wait another 10, 20 years, the people with money and resources who are older will be fine. The people who don't have the resources or the family members to help them, we will see a societal situation just like we did with the first wave of COVID. So those are my passionate 2 cents, because 30 years in this space, Martin, to your comment of coming back, like I've been, I just wish the door would change to be people's doors. And I don't see we're inching there, even with COVID.
Martin, you look like you want to respond to that.
Just a quick point. I think that, what we're talking about in many ways is how do we improve communication? And Michael brought up about the indigenous population. We've spoken about England and Denmark, which are smaller countries. We're a vast country of a relatively small population. And it's very costly to have very good communication, internet services, et cetera, that allow really, really good telecommunication. I can honestly say that 80+% of the patients sent to me as a tertiary quaternary physician don't need to come to me. I could deal with them by telemedicine. Just think of the costs we could save and divert that money into much more appropriate scenarios and issues that are really relevant. And I think what that means is the communication is not only how do we have cheap telecommunications in Canada, how do we have reliable telecommunications? I mean, my router in Toronto, in downtown Toronto, I have to reboot 3 times a day. By now, I would have lost you in this communication. So you can imagine what it's like for somebody up north or in a smaller city. And we have to improve things and go beyond our silo in healthcare and think that healthcare functions independently. It functions because of other things and in concert with other things, and the cooperation, communication is essential.
It really speaks to the connectedness, Michael, that you were speaking to. So I know you wanted to jump in there.
Yeah, no, it really does. And I think many physicians have, knew, and some have been able to actually in the COVID period where for the first time patients didn't want to come in, or at least some of them didn't, see how much potential there is to separate the exchange of information and advice from the actual physical visit. My younger brother, who has a big family practice in Brandon, is probably, and it's inner city, quite economically and disadvantaged patient population, but he's dealing with probably half of them virtually. And there's enormous potential to free up the time of our most skilled providers to focus on what only they can do and what needs to be done, rather than having this kind of endless procession. And we apparently as a country bought rapid tests, but then put them in a warehouse somewhere because Health Canada wasn't sure that they wanted rapid tests that weren't going through a lab. And there's times when you just feel, and I had an early experience of this, and I'll tell it because it's a story on myself. After I left the Manitoba government, I did some work at St. Boniface Hospital, leading a kind of transformation project. Now, this was mid-'80s, and I was with KPMG, and we did a whole program prioritization thing. And one of the recommendations was to move the 23-bed, going by memory, eye surgery program to a day surgery program. And this was my first experience of just how one surgeon could destroy like 6 months of work. The surgeon in charge of the eye surgery program went before the board and said that this was nonsense. This was going to people would go blind. This was if they didn't have a 3 or 4 day length of stay after a cataract surgery, and like this whole thing. And I was summoned as a non-physician to answer for my crimes of consulting advice. And I said, before you hang me, would you let me talk to this? And this surgeon had been in the paper, and it was a big issue. And they said, well, what are you going to do? And I said, well, I'd like to take him on a trip. And they said, well, what kind of a trip? And I said, just leave it with me. So I convinced this surgeon to go to Loyola University in Chicago. St. Boniface was a Catholic hospital. Loyola is a Catholic hospital health system. We went down there, and I'd set up for him to meet the head of, eye surgery there, and toured him about. And they were doing 90% of their cases on a day basis. And he came back to Winnipeg and went to see the CEO of the hospital in the board chair and said, I've seen the future. And just leave me my budget and we can do this. And they did. But sometimes I think we would be better to buy plane tickets for people who turn into resistors, and just because seeing's believing. Like, if you're not, another surgeon in the same specialty, you don't have credibility. Like when I was chairing the Cancer Quality Council, and we discovered that for colon cancer cases in Ontario, the gold standard is you get, I think, 20 nodes from around the surgical site, send them off to pathology, have them read, and if they're clear, then you're stage 2. You don't have to do adjunct therapy, and if they're not clear, then it's stage 3, and you've got to do some chemo or radiation. And Andy Smith, who's now, I guess, CEO at Sunnybrook, was a leading colorectal cancer surgeon, and he agreed to go around the province and meet with all of the colon cancer surgeons and all of the pathologists, and then take them out to dinner, like together, and say, here's the standard we're trying to get to. And we were only at about, 12, 15%. And over 2 years, we got up to 80%. So we gave him an award. Hartley Stern, who was heading quality for surgical care out of Cancer Care Ontario, thought, let's give Andy an award. And I told this story. And then in presenting the award, Dr. Stern added, by my calculation, moving from, the teens to 80%, probably saving something on the order of 200 lives a year. And it convinced me that there are all sorts of improvements we can make. They're not going to stop a pandemic, but if you save 200 lives a year here or there, or even 20, you're going in the right direction. And so we took that approach, and Cancer Care Ontario did have a significant impact on improving the quality of care, particularly for things that were not done frequently enough to be done everywhere. They should be done, by a team that do a lot of them, that whole volume issue. And you have to tread carefully, because you don't want to say everything needs to be done on University Avenue in Toronto, because that's not true or optimal either. But it's a lot of sleeves rolled up work, and it only works if we can stand down some of this inter-silo kind of conflict. And the reason I joined the St. Elizabeth board after being Deputy Minister of Health was I thought home care could be the great integrator. And then I discovered, 20 years later, that the instinct of the ministry was to make home care into another silo, not as the great integrator. And so instead of fully getting all the dynamism, there's this kind of, well, you're in a silo, you've got rules, and we're just and at the coalface, these things break down because people at the end of the day, to the extent they can, do what's right. So even if it's supposed to be siloed, they go, well, we're just gonna do this right. But too often the silos even prevent the conversation, that it's hard to sort of say, well, we could vaccinate a lot of people without pulling them out of their homes, using the home care nurses. But we can't do that if the home care nurses are working a shift at a long-term care center. So we learned from SARS, don't have nurses working at 3 different hospitals because they become the vector for the virus to be transmitted. We didn't apply that to the non-hospital sector, and that cost us both time and lives in the front end. And a personal story, the mother of someone very close to me, who's living at home with care in Brampton, got her vaccine last week. She's 84. And there was an attempt to move her to a nursing home just before the pandemic hit. And the nurse who led that charge on behalf of the LHIN to say, oh no, you got to move to a nursing home, was herself working at the LHIN, working shifts in a nursing home, and doing home visits. And she contracted COVID early on, nearly died, and undoubtedly contributed to the spread. So just to say, we've got a lot of capacity to do better, but we do need to stand down some of the vertical kind of thinking in terms of more integration on the ground and more kind of envelopes of funding that let people do what's appropriate rather than, well, I'll tell one last story. When I was deputy, I had a group from Northern Ontario come, Indigenous leaders, and they were they built some healing centers and some healing lodges, and we'd funded them, but they said, 15% of the funding for all of these facilities is reserved for psychiatric care. And I said, yes, that's the funding for it. Well, what's the problem with that? And they said, well, there isn't a psychiatrist within 800 miles of our community. And we actually think we're making more progress with troubled youth with the healing lodge. And we're just wondering if, since we have to not spend 15% of the budget, could we, have a rule that says if there isn't a psychiatrist within 500 miles, it would be okay to, spend the money on what we're doing. And I agreed, and then I got beaten about the ears for about a year by everybody involved with psychiatry about this. I said, we're still paying if there's a referral out, you still get paid. But, it just, if the community can heal themselves, then maybe that would be better than, flying young people out into a setting where they're really alienated and don't know what's going on. Anyway, there's lots of examples of how we've, been too, vertical in our thinking and not horizontal. I'll stop there.
Okay, well, Michael, it's interesting because it does really speak to the capacity, that we do have and that does exist, both within the communities and the resilience and the capacity within communities, such as First Nations, Inuit and Métis communities, across the country, but communities of healthcare professionals, the capacity that we're concerned about right now that we don't have. But I think it's a matter of looking at doing something different with that capacity to, in fact, create more capacity. And the silos and the lack of interconnectedness certainly, and tradition certainly puts barriers to those types of things. But I'm wondering, I know we're going to be running to a close soon, but just wondering in terms of each of you, Reza, Natalie, and Martin, if you might just comment for a couple minutes on what you've learned over the past course while and with the support of the Michael Decter Scholarship in terms of your education and ongoing experience, or what you hope to learn through your studies, Reza, that you think might address some of these issues that you've all been talking about and that Michael so clearly laid out too in terms of his experience and observations. Reza, do you want to start?
Yeah, sure. Okay. I think over the past 2 terms, the overall theme of the courses that I've taken and the things that I've learned from EPI to biostatistics to planning and evaluation and so on, all of them, the way that they can help me to contribute to the healthcare system in Canada would be, one of the ways would be to help me appraise the current evidence or help create a high quality evidence. And so we could, based on that, we could have evidence-informed policies and decisions that could lead us toward the right direction on different fronts in terms of improving the healthcare system. And one example of that, that might not be completely related to healthcare systems, but one example of that was I was quite a bit involved with the BC COVID Therapeutics Committee, and the thing that they did was constantly they are constantly evaluating the current evidence for the therapeutics that are working for COVID. And the Michael Decter Scholarship has definitely helped me to learn the skills that are needed to appraise those evidence that are quite large. I think we have more than 2,500 trials right now just on therapeutics for COVID. So differentiating between them and choosing the best one and guiding the policymakers or decision makers in the right direction, I think would be my goal.
Great, great. Thank you. And such critical at this point in time as the evidence is constantly changing, and we're all looking towards those individuals that can summate that for us and give it to us in a way that can be utilized as well to making decisions around policy, practice, and care. So thank you. Natalie?
Yes, so the Michael Decter Scholarship really afforded me the opportunity to focus my energies on completing my doctoral dissertation, which was caregiver support policies in Ontario and analyzing the pace and direction of policy change. So my doctoral dissertation looked specifically at informal caregivers and analyzed through mixed methodologies, a data set that I helped to gather and curate through work that I had done at the Alzheimer's Society, directly impacting persons with dementia and their informal unpaid caregivers. Mark, on a comment that you made earlier, Michael, just around thinking differently about bundles of funding, and what we did, and in this project that I helped to develop, this caregiver support project, is we thought a little bit differently around how home care, even the LIN or even many of the community service providers were delivering home care services. And in Toronto, unlike the north of Ontario or unlike more rural parts of Canada, the problem there is they don't have access. Now in Toronto, the problem is there's too much to access and weird geographical boundaries and weird eligibility criteria and cost, right? So it's challenging as an informal caregiver dealing with somebody with dementia 24 hours a day to navigate, where do I get service? How do I get the service? How do I pay for the service? So we developed this entirely de novo basket of service, which the basket of service could have been respite for yourself, incontinence products. It could have been all kinds of stuff to really ensure that that family member was able to continue to care and keep that person with dementia at home for as long as possible. So, at the bottom line, I guess at the end of the day, what the scholarship afforded me was a fundamental opportunity to learn about patient-centered approaches to healthcare delivery. What does the patient need? What does their family caregiver need? And, that to me is still the next frontier of healthcare. We're still learning how to partner with patients to design treatment and interventions that are most suitable to them. We're still developing individualized oncological therapeutic technologies because now going from this is what chemotherapy used to look like to individualized, immuno-focused, it's a shift because there's something unique about that person. So I think that's the future. And excellent conversation again today. So thanks.
Thanks so much, Natalie. Martin?
Thanks a lot. It's great listening to Natalie and Reza and what they've gotten out of their scholarship. And I want to thank all of you for your support. And for an older person like me going back to school at McGill. And my focus when I started, obviously COVID was not evident to any of us at that time. But I was still interested because of my background in quality improvement, patient safety, is where do healthcare workers' mental situation, how does that get correlated with patient safety and the quality of care that we provide? So my focus in McGill has really been related to second victim syndrome, which is something unique in healthcare, as well as moral distress And how does that lead to burnout, which is something that is like also a pandemic right now? Everybody is burning out to some degree. And I think COVID has just added another layer to that because it's another stress to people within the system, again, probably expediting the road to burnout for many people within healthcare. So I haven't got solutions. I mean, I think that's the beauty of conversations like this, is to see how other people think and learn with and from one another, rather than saying there's a right way or a wrong way. Is the British system better than the Danish system, better than the American system, better than the Canadian system? And the problem is we have to look at all the systems like Michael did when he was in Washington and say, how do we take things to the next step? And sometimes people say the enemy of good is better. Well, healthcare has to be better. It has to be something where we're always striving for the next step. When Michael's father and uncles were in medical school, medical information was doubling every 20 years. When I was in medical school, every 7 years. Now it's every 6 months. How do we give people the education, especially when the media and the way things are now transported to the general public? People are coming in and telling us what to do. There's so many wonderful stimuli that are available to us to improve. And we just have to keep looking at that as the constant for all of us who care about the healthcare system.
Great. Thanks, Martin. And before we go to Michael, Shirlee, is there any last words that you wanted to share?
Couldn't say it better. I really think all three of your remarks, I'm nodding and going, yes, yes, yes. So couldn't say it better from every perspective. Thank you. And it's wonderful to see this commitment and investment from SC Health in all of you is bringing out some amazing thinking and hopefully some real changes in the system. So thank you.
Great. And Michael, as our guest of honor, over to you.
Well, this just fills me with optimism and pride, and I thank all of you. I mean, it was nice of SC Health to create the scholarship, and it's wonderful the work you're all doing as a result. I know it's a small part of your education and work, but clearly you've had some really important insights and an ability to pursue them. And that's the hope I have for the future, is that we come out of this pandemic not thinking that we should, stay the same, but that we've got to really think differently about how we do health and healthcare, and how we make people less vulnerable, and how we, how we protect the providers. Medivy, where I am now, are because we have paramedics, we're trying to fund a major center of excellence in PTS. We also run the benefits program for Veterans Affairs. And so we put together a virtual roundtable. We didn't want to not do it because of COVID. And we had 3 leading experts globally who were all eloquent and so on. But the person who, in my mind, really stepped up was, we have a young fellow, Matt, who runs the ambulances in New Brunswick. And he said, he was part of the panel. And he said, the first year I was working as a paramedic, I was pretty young. He's still pretty young. I've almost got him to stop calling me sir. But he said, I transported 5 suicides that were all teenagers. And I was completely floored, because I thought of PTS as someone who's been to war, a paramedic who's witnessed a terrible bus crash or car accident, or I never thought about the trauma of transporting someone younger than you that's taken their own life. And it really rocked me, because I thought, we haven't got our arms even around the kind of trauma that people who've not been to war, who haven't witnessed some mass event, our paramedics transported the children of victims of the Nova Scotia shooting after their parents had been shot and killed. And you know, there's just so much to be done to not only heal people who are injured or sick, but to heal the caregivers that are, you know, traumatized by the actual work they're doing. And, you know, there's still so much to be done. And, but I do look forward to lunch. If we can eventually arrange it, that will be good. So thank you for everything you're doing. Thank you to SC Health for making this event happen. A real privilege to be part of it.
Thank you, Michael. Thank you. And thank you everyone for joining us. I mean, wrapping it up on, there is still so much to be done. And I think it's great to see that with the impact of the scholarship, Michael, and your recognition that we have more people to help us to do the work that needs to be done. And I think this has been a very insightful conversation, and we have a bright future ahead. So thank you all very much for joining us this afternoon or this morning. And we look forward to staying in touch and doing lunch.